I actually grew up in San Diego. My brother was bar mitzvahed at the Hotel del Coronado. So I forced Chris and me to go to the Hotel del Coronado and go to the main banquet hall where they must have had some event for this Morningside recovery. And just to show you, we all do things differently. Pet-friendly detox and inpatient. We are doing this all wrong, people. I'm just saying that right off the bat. California, and what I've never been quite sure is I don't know who's getting detoxed. So is catnip okay? I don't know. We could do that as a subject later. So, all right, starting this one. So to be honest, this was actually a presentation I curbed from our last time when I spoke because we decided to talk about weaning Suboxone. And when I originally made it, I really made it about like kind of why not to use cannabis and MAT, right? And kind of, I think I had a lot of free time right now, so I've been watching a lot of lectures on cannabis. So I have to be honest, I have to acknowledge there's a lot of people who have contributed slides to this presentation. Like I told you, I got up to 90. But one of the things I kind of framed is I know why I don't do it. I think this is a much bigger conversation. It's kind of like the harm reduction versus abstinence model. You have to decide where you are with this, okay? And so rather than me say, hey, this is no good, and to be honest, I can present you lousy data. It is lousy data on both sides of the argument, and you can find it from everybody. I'm going to walk you through a little bit about what we know about cannabis. I want to walk you through some of the arguments, and that way you can actually have a motivational moment with your patient, and we can talk about, and I'm going to show you some studies, but I want to walk you through so that when your patient tries to come at you, you have something to respond to them with, okay? Because you have to know how we kind of got here, I think, a little bit. I think this is more of a history with some understanding. So I want to start off by saying the first commandment is thou shalt not shoot the messenger, okay? This is a safe place to have a discussion, all right? And what I say, I actually hope we have plenty of time. We can debate this. I'm sure we could debate this for another 2 hours when we're done. Maybe not, depends. So I want to start off because this first little study, I'm not going to get into the depths of it. It was a systematic review, but really, I want to draw you to the point. These were healthcare providers, and what they said is, these are the major points they took away, which is primary health professionals are relatively supportive of medical cannabis in clinical practice. But they kind of back with lack of confidence, lack of self-reported competence, and concerns for associated risks. So people are interested in doing this. I think the second thing they noticed, universal self-report is lack of knowledge regarding legislative and clinical domains. So when those questions start getting answered, they're going to do this, okay? When they feel better with it. And then finally, there were the final two outcomes was, are they causing harm? We know there are psychiatric adverse effects. And ultimately, then they were worried that there would be recreational misuse. So it's coming. And we know it's coming. It's already in the state. In fact, if you went to the OMAS, I thought it was interesting. We had a neurologist come who prescribes and basically said, I feel like a lamb to the wolves. So let's go through a little bit of cannabis, okay? There are basically two types of cannabis. Some of this may be rudimentary. I think it's good to know, okay? When you talk about, there are two, they're indica and sativa. Sativa tends to have a higher THC to CBD ratio compared to indica. When you talk about the vocabulary, you talk about cannabis, that's a collective term for the genus of the flowering plant. When you talk about marijuana, it's a mixture of dried leaves and flowers. When you talk, and that's of the sativa. When you talk about hemp, there's a couple different, most of the time we think about it as industrial hemp. And typically industrial, the foodstuff product contains less than 0.3% THC. And then when you deal with hash or hash oil, you're dealing, with pressed resin or oil expressed from the pressed resin. When you look at what makes up cannabis as a general, you're talking about 540 chemical constituents, about 104 plus or cannabinoids, and they all have their own complementary pharmacology, and that's what they're kind of promoting for different things. The only one that technically is THC is considered psychoactive. When you look at the multiple extracts, they form new products. And then people say, hey, we can use it for all kinds of things, and this is what people are looking into. You do remember there are some cannabinoid plus non-cannabinoids, terpenes and flavonoids are also in the product. So when you look at the active chemical constituents, this is the big two, obviously, is what people describe as CBD. You can see there's a laundry list of other things there, and then the delta THC. Again, When you look at CBD, what does it do? It has an effect on THC and decreases other effects of the THC. Again, THC being the psychoactive component. When people talk about CBD oil, right? We hear about this all the time with, I'm using CBD oil. It's extracted specifically from flowers and leaves of the plant. The manufacturers claim it to contain 99.9% CBD or less, and less than 0.03% THC. It's primarily being used for medicinal for treating a wide range of clinical conditions. When people talk about hemp oil, which is the other thing, this is from the seeds of the plant, and typically from industrial hemp. It's used as protein supplement in lotions, creams, and soap. It can contain small amounts of THC and as much as 24 parts per million of CBD. So again, CBD being the non-psychotic increases some of the effects of THC and decreases other. This is what they describe as the anti-inflammatory, anti-fibrotic, antioxidant, neuroprotective, anti-epileptic. And they've used it for all kinds of things. I wanted to start off with this very famous study. This is the problem with CBD, okay? Right off the bat. This was a Dutch study. This was a physician. He went around, and I think if I have 2 slides, yeah, it's like 21 samples. And he went around and said, okay, this is what it says on the label. What did it actually, when I went and tested it, what did it actually have? How much, so for example, so label says 27%, guess what? It only had 2.3%. The THC was labeled 17, it was 0.01. So the answer is you don't know what the hell you're getting in the stuff. Sorry, I swore today, all right? And that's kind of how you have to look at when these CBD products. Why? These are not, so there's a process to, if you want to put this kind of stuff on your label, you can send it to a lab. I don't think, somebody can correct me, but at this point, I don't think there is an FDA or an FDA approved lab at this point. And so these labs, you send the sample, they test it, they send it back and say, well, this is what your sample had. At that point, you do not have to regulate your sample. You said this, we tested it one time, we never had to do it again. It's not mandatory, tough noogies. And that's what happens. So these products really don't have control. So again, you don't know what's in it. So for example, when my patients come back and they're positive for THC and they say they're not doing anything other than CBD, I say, well, you know, stop doing your CBD. It's clearly problematic. Again, 2 slides to explain that. I threw this slide in real briefly. Does cannabis affect other drugs? The answer is yeah. THC induces CYP1A2, so you can see the reduction in clozapine, duloxetine, naproxen. You can see olazapine. It can affect our some of our medications. When you look at CBD, it inhibits CYP3A4 and CYP26, so you can have increased serum levels of macrolides, calcium channel, benzodiazepines. So as a general kind of rule, overall what I'm saying is cannabis can enhance CNS depressant effects when combined with alcohol, barbiturates, and benzos. Probably not so much with the opiates. That's probably what we know. Again, and this is another, FDA did a report of inconsistencies as well in CBD products. So you can kind of see, again, from 2015 to 2016, tested lots of things. Some products didn't even have any CBD in them. So, but that nevertheless, you get a great picture like this. This is how they advertise, right? I love it. One medicine for hundreds of conditions. The perfect drug, right? Awesome. So in that, I'm going to walk you through the history a little bit because, you know, a lot of what we see, you have to, I always say it's good to know. CB1 receptors were only found in 1988. That was Devane, Alan Howitt and her graduates were in Devane. By 92, they had actually found a hormone. They found basically endogenous cannabinoid in our system. It's called anandamide. It means bliss in Sanskrit. The Israelis found it. Yay to the Israelis. By 1993, they had found the CB2 receptor. This, if anybody's really good at chemistry, what I'm basically being told is these molecules look the same, more or less. Okay? Don't ask me why. One's purple, one's green, but they look the same. But really the more interesting thing that I take away from this is, so they basically were able to say, what's the receptor, the CB receptor, what's the affinity of the CB receptor for each of those, the endogenous versus the exogenous being the delta THC. And what you see is it's about a 2 times more potent relationship for THC compared to your endogenous anandamide. I always like to leave in the background this, I think, study, and I can't see it because my little thing, I think it's from forget which year this, 1999. Thank you. So basically what we know about the endocannabinoid system is it really acts as a volume control. And this is what I talk to my patients all the time. People have heard me say this. I go, it basically causes little blurs to kind of, if you're feeling anxious, yes, it will bring you down. If you're feeling, hungry or maybe sedate a little bit, it just regulates. And the problem is I always say, what happens when you monkey with the volume control? The answer is the volume control. Your dad says, don't touch the volume. It's going to turn up louder. So therefore, people say it's the only thing that helps with my anxiety. Well, yeah, because it's making your anxiety worse. It's that vicious cycle. So you use more, you know. All right. Oh, this didn't show up in the good blue. Ah, darn it. So I changed the color right before I presented. Big mistake. Keep it to white. So I love history. People who've talked to me know this. I really want to take you through a couple of interesting points. In 1990, this is where this is where the beginning started, really, in my mind. Unless you really want to go back to Nixon in the 50s, I do not. So, in 1990, the Institute of Medicine poses compassionate use to release suffering in terminally ill patients. Right, same concept we used to hold for prescription pills. Right, surgery, cancer, and palliative, right? That was it, man. After you didn't get it. So they said the same thing. Why don't we use this for compassionate use for the terminally ill? Said fine, makes sense. To be honest, this was probably the death stroke for a lot of research into medical medications related to cannabis. Why? Because now they said, okay, the plant's out there. Why would I start working on a multi-billion-dollar product? And then basically, once you open the door, that's where California passed the medicinal marijuana ballot in '96. By 2012, we had legalization in Colorado and Washington. And by 2017, we have 29 states and DC have legalized. And that's kind of where we kind of moved. We kind of kept moving the needle from there. So I always say, when you allow legalization, you allow industry. So this is the industry now. This is what we're seeing hitting us, okay? It's not just Willie Nelson's weed anymore. We got vapor, we got capsules, we got sprays. I mean, you name it, they're putting it in everything. I don't know that's grandma's cookie. I don't even know what grandma's cookie is like anymore. You know what I mean? Don't eat grandma's cookies, but you can see it's there. So I got it. I should never have gone to the color blue. What was I thinking? It screwed up all my. So this study, and I've showed this study in every presentation I do. This was a study where every time the DEA made a bust, they would test the concentration of THC. Before 1995, we were running, and these are the leaf products. These are the vegetative products. They were less than 4%. By 2014, we were up to 12% THC concentrations. In fact, it was interesting. One of the slides or one of the presenters in the slides I used, he used to work at Ole Miss University. A lot of people don't know this, but Ole Miss is the only, and unless something's changed, was the only DEA approved university to study cannabis. They were doing it for like 40 years already. And they said the highest concentration they ever ran up until recently was 3.7. So they weren't even using that strong. So again, this is not your father's pot anymore. So you can see, I won't go too far into this, but you can see how again, this is saying the same thing. The strains have changed by 2017. Like I said, 30, 40%. If you're dealing with what we now see, which is Dax, shatter, and wax, these are concentrates that they basically use like butane and soak in butane and make this waxy film stuff. You can get up to 90%. I had a guy who was vaping, who was a Vivitrol patient of mine. He said it advertised as 99%, but you can see we have increased the concentration significantly since 1990s. So let's be very clear. When we talk about cannabinoid pharmaceuticals, there are really only 4 products that exist. I just want to mention these real quickly. There's Epidiolex. This is a CBD product. It is for Dravet syndrome in children. That's the only approval. There's Sativex. It's by GW. If you're wondering, the little GW is the name of the company that makes it. It's a 1-to-1 ratio of THC to CBD. I think it's now legal in 25 countries, but not in the US. It's used, I believe, mostly for spasmosity. There's Dronabinol, Marinol. This is a synthetic THC. It's for appetite stimulation and reducing nausea. Funny story, when I was a pediatrician, I had a very sick kid who had some abdominal surgery. He was actually placed on Marinol, and his parents refused to let me tell I was only allowed to refer to it as his medicine. They did not want him Googling what it was. So, and then there's sesamet or nabilone, again, another synthetic cannabinoid, similar to THC for treatment of nausea and vomiting, but only in cancer treatment. All right, if that isn't enough history, I want to push a little more. This is, I think, the study that gave, especially since now I want to start moving towards MAT. This is the study that pushed a bunch of people to believe that cannabis is good for your opiate use disorder. Okay, this is the one that they all said, see, we're helping people. And what they basically said from 1999 to 2010, there was a study done that said, okay, we have overdoses. We know that overdoses are driven by prescribing of opiates for chronic pain. Well, marijuana is for chronic pain too. That was their argument. So they said, okay, the states that have medicinal marijuana, let's look at their mortality rate compared to the ones that hadn't. And what they basically determined out of all this was about 24.8%, called 25% lower mean annual opioid overdose mortality rate compared to states that had no medicinal cannabis law. Okay, so they said it's significantly lower, right? That was the conclusion, which allowed street signs like this to come into fruition, right? It's legal, it'll keep me safer, I won't die. You can have multiple things be true and not related, all right? What we found is they claim this, but what they didn't take into consideration is the states that had legalized, first of all, there was a few different events that had occurred at the same time. One, they were cracking down on, remember, it said prescribing opiates. They were talking about prescriptions. We were cracking down on prescription opiates at that time. So we already had a drop in prescription opiates. The other part of this that they didn't really take into consideration was fentanyl had not come to the marijuana states that had legalized. So the problem is we were getting hit with fentanyl deaths. They weren't yet. And so they basically looked at this data and basically it reversed when you looked at the data farther out. So this is kind of where that changed, okay? So this is just that slide showing that. By 2010, the numbers were going back up again. Like I said, two things can be true. You legalized marijuana and you had a period of time when your opiate-related overdoses were going down. The connection wasn't, I think, a true connection. Still focusing into the 2017, I think this is the last part of history I'm gonna give you guys, okay? This was the other, a lot of people, we've talked about this. I think it's good to talk about. Interesting that it was supposedly this big study to come out. It was gonna be a game changer. And you probably never heard of, probably most people haven't heard about it. Probably we have. But there was, they basically did this report called The Health Effects of Cannabis and Cannabinoids, Current State of Evidence and Recommendations for Research. This was made an ad hoc committee of the National Academies of Science, Engineering, and Medicine. And they were going to categorize the weight of evidence, and they listed it as conclusive, substantial, moderate, limited, no, or insufficient evidence. I've given you the link. If you want, I can send you a hard copy if you want. It's about 486 pages. It is boring. Maybe somebody else feels differently. I'm going to say it how it is the most I don't know if anybody wants to come with a good word. I'm willing to let you chime in now. It didn't go anywhere. And I'll show you an example of why. So actually, I'll get to the example of why. I borrowed these from some colleagues in California in their presentation. They tried to do some MI related to this study. And what they did is they tried to create they basically took the report. The report basically talks about the evidence and then kind of says there's a final conclusion. I'll show you what that looks like in a second. And they kind of created these associated risks. Sorry. Associated risks, and then they kind of put in substantial evidence, moderate evidence, limited evidence, no or insufficient. So they kind of say this is how we do MI. I don't want to get I kind of want to get deep into this, but I only got a few minutes to do. So you can see, if you want to look at this, come back to it, basically talking about the respiratory being moderate, schizophrenia being a substantial evidence, but everything else kind of pans out. By the time you're kind of at the end, in my mind, it doesn't show that it works pretty good. I mean, if anything, it makes things worse, not better in my mind. So again, then they also list the therapeutic benefits. Again, some conclusive, they try to say substantial evidence for chronic pain, antiemetic, spasticity, you can see, go through the chain. Again, I want to focus, we're talking about MAT patients today, but if you want, you can come back to the slide. I think it's a nice little kind of overview of it all. When you get into the report, okay, This is pretty much all they have for opiates. Maybe I'm wrong, but this is all I found out of 400 and something pages. And basically what they said, the committee did not, and to be honest, this is pretty common throughout the entire report. The committee didn't, they say this all the time, did not identify good or fair quality systemic review that reported an association between cannabis and the rate and use patterns. What I'm going to skip ahead. They basically show you one piece of literature, 12 to 18-year-olds, and kind of walk through it. But basically, at the end of every chapter that goes through each of these subject matters, so this one was opiate, they do a box conclusion, and this is the summary. All right, it's to me, it's a big nothing burger. Moderate evidence of statistical association between cannabis use and the development of a substance dependence. Drug abuse includes alcohol, tobacco, and illicit drug. That's what they conclude. There is limited evidence for the initiation of tobacco use, fine, changes in the rate of use pattern of other illicit. So to me, not much I could do with that. That's my opinion. Mind me, please remember, this is my opinion. Don't shoot the messenger. I'm showing you one of my favorite slides. This is the Dunedin study. For those who don't know, Dunedin's been going on for about 40 years now. It was a developmental one. And so the original patients are now, they started off at birth, they're now in their 40s. And what they basically found is MJ stands for marijuana dependence. And basically what they, see, I should never change the color. That was my mistake before I did this presentation, my apology. Roughly, for the people that basically are marijuana dependent, there's about an 8.5, 10-point difference in IQ compared to those who have never used. So we know, in my mind, this is causing, I always think of Dr. Moss where he says, a lot of our patients act like children. I think so, and I think this is part of the, part of the reason, if a lot of them have cannabis use histories. All right. Number 2 is telling me to silence my phone, it's ringing. So this is another one. This is a meta-analysis. So when people try to say schizophrenia is not really a problem, and I'm showing you 6 different studies that say you have odds ratios anywhere between roughly about 2 to 6.8. The 6.8 actually, they kind of varied depending on which study you looked at. What they were looking at is if you had a family history of mental health versus no family history of significant mental health. So if you did not, and you were a significant marijuana user, you had a 2 times odds ratio. If you had the history, more like 6. So there you go. I love this picture. Sorry, I don't have coronavirus. I'm coughing because I smoked weed. And so really we move on to, so what can we do? See how we're doing on time. So much. Starting off with Narcotics Anonymous. Why do we care, right? The answer is because it says it in the book. We put great, and I don't mean that in an insulting way. If you look, these are people that describe having a problem. They say we put great emphasis on this, for we know that when we use drugs in any form or substitute one for another, we release our addictions all over again. And so we are people with the disease of addiction who must abstain from all drugs in order to recover. That's from NA, okay? As of now, there are no FDA approved drugs for the treatment of cannabis use. So what does that really mean? General recommendations for the medications that they use typically focus more on reducing withdrawal symptoms. I have these 2 slides. I'm not going to spend a lot of time on them, because honestly, I really do want to have time for discussion. But basically, I got this from another presentation, but you can see I actually was going to present each of these separately, and then I realized I had 90 slides. This is an overview. Basically, you can see they've used naltrexone, they've done gabapentin, they've used N-acetylcysteine. N-acetylcysteine for my population, specifically adolescents, actually seems to be more helpful. As you get older, it does not seem to work, very well. But you can see it helps with odds of negative urines. Nabilone. I really think this is an interesting thing, this FAAH inhibitor. This is being studied right now. This is basically it inhibits the breakdown of natural anandamide, and so to, I think, arachidonic acid, or I think that sounds right, something like that. And basically, so the idea is it's trying to boost your natural level of anandamide in your system, which I told you is kind of the comparison of THC. These are the things that have not seemed to be helpful. You can read them: buspirone, bupropion, zolpidem, dronabinol, oxymol, and Robinette. I can't pronounce anything today. I'll leave you with this. The gabapentin, the N-acetylcysteine, maybe is promising, but mixed. It probably requires further investigation. the THC preparation may be developed in the future to show efficacy. Like I said, the FAH looks interesting. Again, the SSRIs, mixed antidepressants, atypicals, probably do very little. And this is, mind you, these are, and I'm just talking about cannabis use disorders, not with MAT. All right, we're almost there, people, I promise. So let's talk about cannabis use and opiate use treatment outcomes, right? Let's move into what we're here for, MAT. 41, this is the church in 2001, did 41 participants in OUD, observed oral naltrexone behavioral therapy. Treatment target opiate use and no contingencies related to non-opiate use. 13 were cannabis abstinent, 13 were intermittent users, and 10 were heavy users. And what did they find? No change in treatment retention, oral naltrexone compliance, or opiate use related to cannabis use. All right. Mojarrad in 2014, they had 563 adult patients in an addiction health evaluation. They recruited from residential withdrawal management units in Massachusetts based on 274 who had cannabis use in the last 30 days, 261 were abstinence. And what they basically found, marijuana use was significantly associated with 27 reduction in the odds of abstinence from other drugs and heavy alcohol. All right, so this one's now saying this maybe seemed helpful. Hill in 2013, 152 youth ages 15 to 21 with opioid use in outpatient buprenorphine clinic, 25 daily cannabis, 50 non-users, 77 occasional. And they basically drew no association between concurrent cannabis use and opiate use. And there was no association. And basically they said participants reduced opiate use in response to treatment, and cannabis use was constant the whole time. Again, so not, again, I'm just presenting you the data as I know it. So seemed like treatment's good to help with one thing, but the cannabis didn't really change. That's what I draw out of that. Maybe we can argue this later. So Bundy in 98, 79 adults with an opiate use disorder in an outpatient buprenorphine clinic. Again, cannabis users continued to use cannabis throughout the entire study period, 12 months. Users were and what they found is no difference in retention and treatment, illicit or non-prescribed opiate abstinence, other substance use or ASI scores. The only other interesting thing is they found the users tend to be less likely to be married, more likely to report financial difficulties, be involved in drug dealing, and engaged in sharing needles. So just an interesting thing. So clearly there's some bad behaviors associated with your continued cannabis, maybe. This is, so which one is this? Is this the methadone? No. Yes, this is cannabis use during methadone maintenance treatment. I think this, hopefully, and this was from 2019. This was something a little more recent. They did a meta-analysis of 6 different studies, which included about 3,600 participants. The overall quality was low. There was a high risk of bias owing to the nature of the observation. And we found no consensus among studies that cannabis use is associated with reduced opioid use or longer treatment retention. All right, I tried to give some time for discussion. I draw from this, for me, this is again, where you live on the spectrum. I want you to be armed with the ability to have an informed discussion. For me, I still draw off the basic conclusion. You're a diabetic who loves chocolate. I'm not gonna allow you another substance that is a cookie for your diabetes. It's all sugar to me. And so that's how I run my program. Now, does that mean I don't have positive urines for cannabis? I get them all the time, but I do use that as a reflection point to say, look, maybe that's more important to you than my program, if this is a persistent problem. And that's kind of where I live. Everybody can have a different argument. I really do want to open this up. This was, when I originally did this, I was just saying, no, shame. I think if you really look at what helps these patients, it's being